Hello, and welcome to Lymphoma Research Foundation's update on oral therapies in lymphoma and CLL webinar. I'm Leke, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of the program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certification of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. Now I'm pleased to introduce Jesse Brown. Jesse Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jesse, and whenever you're ready, you may get started.
Great, thank you so much. And thank you to each of you for taking the time to join us on today's update on oral therapies in lymphoma and CLL webinar. We'd like to thank our sponsors of this webinar, Pharmacyclics and AbbVie Company in Janssen, and Karyopharm Therapeutics. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. Before I turn the program over to Dr. Friedberg, I just want to share some information with you on LRF. The Lymphoma Research Foundation is the nation's largest nonprofit dedicated exclusively to lymphoma. Our mission is to eradicate this disease through investment in the most promising lymphoma research and to serve those impacted by lymphoma through quality education and support opportunities. As we continue to make progress in advancing lymphoma research, we also want to ensure that you have access to the latest information about your disease. The Foundation provides comprehensive disease and treatment-specific resources, programs, and services, all of which are offered free of charge and have been reviewed by lymphoma experts. Most relevant to today's call, LRF offers a variety of lymphoma-specific resources, many of which you can access at the bottom of your screen if you're utilizing the web link, or via LRF's website at lymphoma.org if you're on your phone. The LRF helpline can answer your specific questions about lymphoma, as well as discuss relevant treatment options in clinical trials. We also offer the Lymphoma Support Network, which is a one-to-one peer support program for people with lymphoma and their caregivers. The Lymphoma Support Network connects patients and caregivers with volunteers who have similar experiences to help give others strength to meet the challenges they may have to face. We also offer a variety of publications that have been reviewed by lymphoma experts to ensure you have access to the latest lymphoma information. We have comprehensive books on understanding NHL, HL, and CLL, and the transplantation process. Our mobile app, Focus on Lymphoma, is an award-winning app that provides patients and caregivers access to comprehensive content, as well as unique tools to help manage your disease. The app is available for free download in the Apple App Store and in Google Play, and I encourage you all to download the app today. Finally, we've launched our COVID-19 Learning Center to support lymphoma patients and caregivers through this challenging time. Please visit our Learning Center for access to webinars, articles, and other resources specific to COVID-19. I really hope you'll take advantage of some of the great resources and services that LRF provides. If you have questions regarding what you saw or hear today, or if you need information about relevant treatment options and supportive care resources, you can reach out to the LRF through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. And now we have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Jonathan Friedberg. Dr. Friedberg is the director of the James P. Wilmot Cancer Institute and the director of Hematological Malignancies Clinical Research at the University of Rochester. He's also a professor of medicine. Thank you so much, Dr. Friedberg, for presenting today. I'll now turn the talk over to you.
Thank you so much, and I will just echo what a terrific partnership we have with the Lymphoma Research Foundation. I'm a member of the Scientific Advisory Board of the Foundation, and in addition to all of the efforts that were presented, the Foundation also funds research, which is really a top priority, of course, for all of us. So I thank them for this opportunity. And I've been asked to speak about oral therapies in lymphoma and CLL. And obviously this is a very broad topic, but I thought I'd provide some background so we're all on the same page and then leave plenty of time for questions and dialogue. Over the last 10 to 15 years, we've seen a real transformation in the way we practice treatment for lymphoma and CLL. And there's clearly been an evolving use of oral therapies. This was just a very informal survey that we conducted across participants in a workshop that we had about a year and a half ago, speaking about oral therapies. just asking the question, what percentage of your lymphoma and CLL patients are currently being treated for their diseases with an oral oncolytic? And as you can see, many patients are receiving this treatment, and in some practices, it's certainly between 25 and 50%, or sometimes even more than 50% of patients are undergoing this treatment. So it's highly relevant that we have this discussion. I think the question is, why are we even having this talk? What's unique about oral therapy? In most of medicine, we give oral therapy. The treatment of blood pressure is generally with oral therapy. The treatment of infections is usually oral antibiotics. Why is this such a big paradigm change in cancer treatment? And I think that there are a number of factors that are involved. First, with any oral therapy, there are adherence challenges. When I prescribe CHOP chemotherapy to a patient with aggressive lymphoma, I know exactly what that patient is getting, and we can calculate the dose exactly. A nurse gives it, and the patient leaves. With oral therapy, frequently it's a daily treatment over a long period of time, and all kinds of things can happen. Patients may miss certain doses, either because they're busy doing other things or out of side effects or other concerns. So it can sometimes be very hard to evaluate the responses to treatment. In addition, it can be hard for patients to remember to take a pill every day, or sometimes it's 3 weeks on, 1 week off, as compared to coming into a clinic at a defined time, getting a treatment, and then maybe coming back 3 weeks later. Similarly, toxicity assessments are very different. So again, using the example of giving CHOP chemotherapy for large cell lymphoma, in my practice, I see my patients before every time I give that treatment. So I can assess in real time whether a patient is fit for that treatment, whether the patient has had side effects. We usually check their blood work. We do a physical examination, and the patient has a very careful evaluation in order to determine that it's safe and appropriate to continue with the treatment regimen. Obviously, that's not practical. We can't do blood work and a physical exam every time a patient is going to take a pill, which may be as frequently as once or twice a day. So how to evaluate toxicity in the setting of an oral therapy is different. And it's a big change from the way we've often practiced in oncology, and that's another unique feature that we all need to consider and integrate into our practice. I think I've already mentioned this a little bit, but with oral therapy, frequently we're giving this chronically over potentially a very prolonged period of time. For example, in CLL, some of the treatments are given indefinitely or until they stop working. So giving treatment daily over the course of years is quite different from a defined period of time of 6 cycles of CHOP chemotherapy, or 6 doses of CHOP chemotherapy, so to speak, over a 5 to 6 month period. And when you think about the challenges of chronic therapy, the first is long-term toxicity. So, for example, there are defined toxicities that occur after chemotherapy that is given infusionally. Those toxicities may resolve after a few days, and then you're done until maybe you give the next dose of chemotherapy. And generally, we can manage those toxicities because it's for a defined period of time. Even if the side effects are lower with oral therapy, if the treatment is chronic and you have a low-grade headache or you have a low-grade skin rash, when it starts to last for months or years, that's quite burdensome and very different from having some mild nausea that occurs for a couple of days after a defined period of chemotherapy. So we need to consider strategies on how to measure long-term toxicities, as well as to ensure that we're abrogating them in order to ensure adherence. Costs and reimbursement are different in some situations for oral therapy compared to intravenous therapy. I don't want to spend too much time on this because this is highly individualized, but there are some insurance policies that treat oral therapy as a drug benefit, but intravenous chemotherapy as a hospital benefit. And co-pays and other challenges can occur to the patient disproportionately with oral therapy. It should be mentioned that many of these oral therapies, similar to our intravenous therapies, are extremely expensive, thousands of dollars per month. So for anybody, it's going to be important to make sure there's adequate coverage for these treatments, in particular to ensure that the out-of-pocket burden is not overwhelming. Finally, there's a very different clinical infrastructure that is necessary to optimally prescribe, monitor patients who are taking oral therapy. So you don't need an infusion nurse if you're giving oral therapy, but you need nursing to be able to adequately teach patients on what to watch for. We have pharmacists embedded in our clinics, meet with patients and help to arrange for drug distribution. Need reimbursement support, as previously mentioned. So there's a whole infrastructure in the clinic and a clinic flow that has to be quite different. Because our treatments are often complicated and may have more side effects, it's not as simple as writing a prescription for blood pressure medicine and saying, see me next week, how it works. There's a lot more teaching involved and a lot more monitoring that may require phone calls, laboratory checks, and other items in between appointments to make sure things are going well. Finally, I think oral therapy opens the window to a number of new research directions. And understanding what appropriate endpoints are of oral therapy is important. With some of our intravenous chemotherapy treatment, our goal is to cure the disease, meaning have the disease go away and have it never come back. With the oral therapies, in many cases, it's to manage the disease, try to minimize symptoms, and keep the disease away for as long as possible. Anytime you're managing the disease, that has to be balanced against the side effects that the patient may be experiencing from the oral treatment. And we want to make sure we're not trading one problem for another by committing somebody to a very long-term course of therapy that they're not tolerating well. So that's, again, requiring a great deal of dialogue back and forth with between the physician and the physician's team, the nurses and the pharmacists. I'll move to a couple of examples of how exciting oral therapy are. This is a clinical trial that really changed practice, one of several trials that have had similar conclusions, that compared an oral therapy called Ibrutinib to an intravenous-based therapy called bendamustine and Rituxan for patients with CLL. And as you can see, if this is a graph, and every time there's either relapse or progression, the graph falls. So, of course, you start in the upper left-hand corner at 100%. Everybody's starting from the same place. And if the treatment stops working, the graph goes down. The bottom line is you can see that the graph is falling quicker with the bendamustine and rituximab, meaning that patients are relapsing sooner, an average of about 43 months, as compared to the patients who are getting continuous Ibrutinib. So this was quite exciting and really has, again, in combination with other trials, changed the practice as upfront therapy in CLL, such that most patients now may be getting oral agents rather than intravenous chemotherapy. In some of the studies, there was even a suggestion of some survival benefit to earlier use of oral therapy. Now again, endpoints are important here. So keeping in mind that as this treatment is going on, and you can see that the x-axis here is in months, so this is 4 to 5 years of time. In the bendamustine and rituximab arm, the patients are only being treated for 6 months. In the ibrutinib arm, the patients are being treated continuously. So it's maybe not a surprise that patients will relapse earlier if they're off treatment than if they're on treatment. That can be a balancing act, particularly if the treatment is giving side effects. Now, one of the things that we've learned is that there can be some surprises when you're giving treatment for a long period of time. And one thing that evolved only after the treatment was made more widely available was an observation of an increased risk of a heart abnormality called atrial fibrillation with the drug Ibrutinib. Now, it turns out atrial fibrillation is something that can be treated and controlled. It's not an overly dangerous heart abnormality, but it certainly does require treatment. And although the initial clinical trials over a short period of observation failed to show the signal of atrial fibrillation in Ibrutinib, once the drug became commercially available and was used widely, it became very clear that this risk is probably on the order of 6 to 10% over a prolonged period of time. You can see that then going back to a number of different studies, the relative risk of developing atrial fibrillation far exceeds 1, which would be equal risk to not patients who are not getting the drug. And in some of these studies, it's a 4 to 10-fold increased risk of what would normally be occurring if you weren't getting the drug. So this emphasizes if you're giving continuous treatment, you need to watch patients also for a long period of time to understand whether any late side effects can occur. Now here's another study in a different disease, follicular lymphoma, that compared a chemotherapy regimen. And the chemotherapy regimens, it turned out, were a few different regimens that could be used, compared to another oral agent called lenalidomide. Chemotherapy in general was given for 6 months, and the lenalidomide was given for up to 2 years. In this study, you can see that there wasn't a particular benefit from the time to progression in one group or the other, but in fact, they were about the same. And this, again, generates a lot of discussion because although the intent of this study was to show superiority of the lenalidomide, the fact that the lenalidomide is even the same as chemotherapy, which is highly effective in follicular lymphoma, certainly confirms it has an important place in our treatment algorithm. Sometimes oral agents can have side effects that really need very careful monitoring. Another oral agent that we sometimes use to treat both CLL and lymphoma is a drug called Idelalisib, which blocks PI3 kinase, and there's some other drugs in that class. And again, after Idelalisib was approved, the FDA had to come out with a warning that said that fatal and serious toxicities, hepatic, severe diarrhea, colitis, pneumonitis, and intestinal perforation have been described. Now, this, of course, sounds extremely scary. Maybe some of you out there who are taking this drug, and I'm not intending to scare you with this, because frankly, we could put warnings like this over many of the intravenous chemotherapies that we give as well. But I think the emphasis has to be that just because something is in a pill doesn't mean that it's inherently safer than something that's intravenous. And that the physicians as well as the patients have to understand that if you're getting these pills, you have to be monitored very carefully. There's a reason why you may have to get lab work done frequently and see the physician frequently. Even though the pills are available right at your house, you don't necessarily have to go in for treatment. You have to be seen for monitoring. I will say that in the time of COVID, with the advent of telemedicine and video medicine, that has in some cases spared patients from having to actually physically come in, facilitated some more detailed evaluation through those other mechanisms. This slide just gives a bit of examples of some of the oral therapies that are available for lymphoma and CLL. And I want to make a couple of points on this slide. I'm not going to read all of these long names. If you're taking oral treatment, appreciate that I put the generic name, not the brand name, slide. But I want to emphasize how many different drug classes that there are. Just because something is a pill doesn't mean that it's going to all be the same. So the BTK inhibitors work very differently from the PI3 kinase inhibitors, or the immunomodulatory agents, the IMiDs, or the BCL2 inhibitors. So frequently, patients may go from one of these drug classes to another, or more recently, there are studies going on that are combining these drug classes. And of course, when you combine the drug classes, similar to intravenous chemotherapy cocktails, you may have improved efficacy, meaning that the combination may work better or be stronger than one drug at a time. But there's also the risk of surprising side effects that can occur. So anytime these agents are combined, you have to make sure there are clinical trial data to support that. But this just gives you a sense what an incredibly exciting time it is when we have such a long list. And this is not a comprehensive list. These are just some examples of the drugs that I commonly prescribe in my clinic. In the middle, the EZH2 inhibitor and the nuclear export inhibitor, those two drugs have just been approved over the last 3 months or so, just giving a sense as to how rapidly this field is changing. And that list continues to grow as other drugs are under development. Now, I want to just return for a minute to adherence, because this is a challenge that, again, oncologists didn't used to have to deal with. Give CHOP chemotherapy, you know what the patient's getting. When you give oral agents, you may not know exactly what the patient is getting. There have been a number of studies in the HIV literature, in the infectious disease literature, trying to figure out ways to enhance adherence and understand why adherence may be challenging in situations. And this slide summarizes a number of potential patient-related, social and economic-related, system-related, condition-related, and therapy-related reasons why adherence may be incomplete. I'll just call attention to a couple of them while you can read the others. For example, the condition-related, if the disease does not cause symptoms, over time it may be tempting for patients to stop taking the medicine. That makes sense. If you have CLL or follicular lymphoma, have any symptoms from the actual disease, one thing to try to shrink your lymph nodes, but if you have scans that look really good for a long period of time, after 4 or 5 years, it may be tempting to say, oh, I want to take a break from the treatment. And in fact, medically, that might be appropriate as well. But I think it's very important that physicians and patients are aligned with what's actually happening. Because if you were to stop the treatment and the disease were to come back, the physician may perceive that, oh, the treatment has stopped working, I need to switch to something else. In reality, you may be able to restart the treatment that you were on. As you can see, there are a number of healthcare systems and social and economic reasons why a patient may stop taking medication or take it intermittently. I think it's important for all of us in society, but certainly in the medical profession, to do everything we can to overcome those barriers and try to minimize all of these reasons why it. One thing that is often done in the setting of clinical trials is to ask patients to keep a diary so that we know when pills are being taken and whether any side effects occur. And that can be very helpful and allow patients to be proactive. I know the LRF has an app which can be used in this way. are a number of other platforms that encourage patients to be more interactive. It can certainly be helpful for me if I'm seeing a patient once a month to know that the second or third week is a week where a patient isn't feeling well or they're more tired, and looking at a diary together can be very, very helpful. I'll conclude my formal remarks here with just a couple of words about trends in oral therapy. So the first, which I think both physicians and patients are clamoring for, is the concept of fixed duration therapy. Again, for many of the oral drugs that have been approved, the endpoint hasn't always been so clear, and the idea is you can keep taking these medicines until the disease progresses or until you can't take it anymore for whatever reason. Now we're trying to really push to develop regimens where you take the treatment for maybe 1 year or at most 2 years and then you stop. There's a lot of appeal in many dimensions of this approach. In the long term, it saves money and resources. It certainly limits side effects. And with some of our new combinations, it may be more effective. It changes the focus from, again, asking whether we cure the disease. Again, I mentioned combination of novel agents. CLL now, the big randomized trial up front, is comparing the concept of a continuous Ibrutinib-containing to a combination of Ibrutinib and venetoclax. And then both of those arms also have an antibody. And the hope is maybe the combination will allow for shorter duration therapy, has more durability. The results of the trials are going to be very exciting, and I expect over time that's the direction that we're going. I put down the term precision medicine because many of these oral agents are really specifically designed to treat a subset of patients. There's no better example of that than a drug called tazemetostat that's been approved for a subset of patients with follicular lymphoma. About 20% of patients have follicular lymphoma that contains a mutation in a gene called EZH2. And those patients have particular ability to respond to the drug tazemetostat. So there's going to be more and more trends of that model where you do genetic testing of the tumor or other profiling of the tumor to understand, what treatment is best. And then some of these oral drugs may only apply to a subset of patients. And finally, I think another important trend for the oral therapies that are being given continuously is the concept of drug holidays or assessments of minimal residual disease. Basically saying if you've been on Ibrutinib, say, for 5 years and everything looks great, what would happen if you stop it for 6 or 12 months? Is there harm in doing that? Are there sensitive tests we could give that could measure if the disease starts to come back and we could restart it before a patient became symptomatic? And again, I'm not recommending that as a matter of routine practice, but those are some trends that people are looking at in clinical trials. So with those introductory remarks, I'm happy to take questions in the second half here of the meeting. About oral therapies. My practice takes care of all types of lymphoma and CLL, and I look forward to a great dialogue. Thank you again to LRF.
Great. Thank you so much, Dr. Friedberg. That was a great talk on a very important topic, and I know everyone that's listening today really values your commitment to lymphoma and all the work you've done for LRF as an SAB member, so we really appreciate you taking the time today. And now we will get into our Q&A portion of the program. And just as a reminder to everyone listening, please keep your questions as general as possible so that the entire audience can benefit from the answers. If you'd like to ask a question, please submit your question through the Q&A box on your screen. We'll take as many questions as possible, but if you have a question that does not get answered, you can always reach out to the LRF helpline at 800-500-9976. And now we have our first question from online. When does oral treatment have to stop in order to have other procedures, like a colonoscopy or an endoscopy, et cetera?
So again, good question. And I think the question is highly variable from whatever oral therapy you're on. Again, these classes of drugs all have very different properties.
I think he mentioned that he has venetoclax.
Okay. Well, I was going to say that some treatments, just to broaden out the discussion, some treatments you may just have to hold it the day of the procedure, just like you would, with a blood pressure medication or something. Other treatments have longer duration side effects that can affect blood counts and maybe increase risk of bleeding. So, for example, the BTK inhibitors, we generally would recommend holding for a week before and a week after a procedure that could include a biopsy, just to minimize bleeding risk. Whereas other oral agents like venetoclax, you might only need to hold them the day of or the day prior. In any situation, you want to make sure you speak with your physician on what their guidance is. And I think that many of us err on the side of skipping a few days of these treatments, particularly if somebody has been on treatment for a long time, because the risk is low if you miss a couple of doses. And of course, if there is some type of interaction with the biopsy, you want to minimize that.
Great. Thank you so much. Our next question is, has there been any research done on dose reduction and/or ending treatment of Ibrutinib and the effect of remission?
Yes, so there are a number of ongoing studies that are trying to ask that question. And I think that one of the things that have enabled these studies is what the definition of remission is. So you can define remission in many ways. You can do a blood test, and if you don't see any disease in the blood and you have CLL, maybe that's remission. You could look at a bone marrow biopsy, and if there's no disease there, that might be a deeper remission. You can do scans to make sure there are no lymph nodes. That might be an even deeper remission. And now there's technology, again, that we call MRD, or minimal residual disease, where you can look for very small amounts of CLL, so small that you can't even see. And you can define a certain threshold, and if the number of the cells are below that threshold, that's considered a very deep remission. And using some of that technology, there are many investigators that say if you reach the point where you're at a very, very deep remission, there are questions being asked about stopping the Ibrutinib. With Ibrutinib alone, it's uncommon to reach those very deep remissions. But when you combine Ibrutinib with other agents, that's when those very deep remissions become more common. And that's why the studies that I've mentioned of the combinations are often looking at fixed duration treatment. And what's most exciting about this is that the first step toward cure is obtaining these very deep remissions. So it may be an early signal that a subset of patients may be definitively treated. Obviously, longer follow-up is needed.
Thank you. Our next question is, since oral therapies are meant to be taken until they are no longer effective, how often during treatment are scans done to see how effective the treatment is?
So a very important question, and I want to emphasize that that is really a very individualized decision between the patient and their physician. What I will say as a generalization is that as a field, we're trying to get away from doing scans overly frequently. It's not pleasant for patients to get scans. There's a lot of anxiety around scans. And if you get them done too frequently, they can be hard to interpret. That said, I did mention that these treatments are expensive. And if the treatment isn't working, you wouldn't want to be treating patients for months and months because, there's thousands of dollars each month being spent. So there's some responsibility to really doing monitoring. And I think for somebody who's in a very stable situation, most providers would look at least every 6 to 12 months by imaging to make sure that the treatment continues to work well. Although, again, I'll emphasize that's a very individualized decision.
Great. Well, thanks for clarifying that. Our next question is, are there fewer side effects and similar efficacy with Calquen via Ibrutinib as first-line treatment of CLL?
Okay, so Calquen is a brand name for a drug called Acalabrutinib, and I think this is a general question as far as when you have drugs in the same class, how similar are they, and how do you choose among those drugs? So, for example, there are multiple PI3 kinase inhibitors I had on my slide, and there are multiple BTK inhibitors that I had on my slide. Try to pull up that slide here for you to look at while we're talking. And in general, these drugs are cousins, and I guess similar to classes of antibiotics or types of blood pressure medicines, there are often more similarities than differences in these drugs between the classes. Now, Acalabrutinib and Xanabrutinib are newer forms of BTK inhibitors than Ibrutinib. And there are some data that they work slightly differently, and their side effect profiles are different. Some of the side effects that bother a subset of patients with Ibrutinib are less frequent with Acalabrutinib. However, there are side effects that I've seen with Acalabrutinib, like headache, that are more frequent than you see with Ibrutinib. So often what can be done is if you're having trouble tolerating one of these agents, you can try switching to another one and see if you tolerate that better. There are also a lot of other differences. Acalabrutinib is a twice-a-day drug, Ibrutinib is a once-a-day drug, and sometimes, like in other situations, an insurance company may favor one over the other. So I think that when I choose which one to start with, it's a complex decision based on, a side effect profile, patient desire for the way that they take the medications, and whether or not we think one in a situation may be better than the other. Most of these cases, the efficacy seems quite similar across the class. Just to give another example, there's a third PI3 kinase inhibitor that is intravenous called Calquen. So, some patients may prefer intravenous versus oral therapy. The intravenous version of the PI3 kinase inhibitor increases the risk of high blood sugar. So if a patient has diabetes, it's probably not a good idea to use that one. So it's very hard to just say one being better than the other. In some cases, like the question between the between the BTK inhibitors, we do have some randomized studies that can really guide us. And when we look at those comparisons, it's not clear that one is clearly better than the other. What's clear is that the side effect profiles are slightly different, and that enables a discussion with the patient.
Our next question comes from someone who has a question about one of the charts you showed with Ibrutinib, the bendamustine and rituximab. I think it was slide 14 or so. It might be the two before this one. Can you explain the graph a bit, and specifically the number of risks seen at the bottom?
Right. So this is one way that we often look at the outcome of study. If you look at the bottom where it says number at risk, bendamustine and Rituxan, that's 176 patients. Ibrutinib, that's 178 patients. And then there was a third arm that combined Ibrutinib and Rituxan that was 170 patients. So that's at time 0. That's when everybody signed up for the study. If you go out to the 24-month time, there are 100 patients on the bendamustine and Rituxan, 136 and 132. So that is, those are patients who were able to get out that far and remain in remission. Now, the reason why a patient may not get out that far are two possibilities. One is that they've had a relapse, so they come off the study, or maybe the patient was lost to follow-up or hasn't been followed long enough yet. If you look all the way to 52 months, you can see it just says 0. That means none of the patients have been followed for 52 months. So it's important for us in the clinical trials world to look at those numbers at the bottom, because obviously when you get out to the 42 or 48-month range, although the curves look impressive, the amount of data that's really there is quite limited. At 48 months, you're dealing with 11, 22, and only 20 patients really informing those curves, suggesting that it's really premature to make any conclusions.
Great. Thank you. Our next question is, how does oral therapy and chemotherapy combination compare to oral therapy and immunotherapy combination? And does this vary according to subtype?
Well, yes, it certainly varies according to subtype. And I think that it also varies according to drug class. I mean, which combination of oral therapy and immunotherapy are you comparing to which chemotherapy regimen, for example? And I think that there are certain agents that are very hard to put in pill form. So probably the most common agent that we use to treat various B-cell lymphomas is an antibody treatment called rituximab, or there are some other versions of rituximab that are given. But antibodies are very, very difficult to put in pill form because the stomach acid makes it impossible really for antibodies to be absorbed. So, there are some drugs that you're never going to be able to probably put into a pill form, and they're very important drugs for the treatment of lymphoma. The reason why oral therapies have increased are, one is now we have better technology to be able to put more drugs into pill form. Second, the classes of drugs now that we're studying lend themselves well to pill form. And third, I think there's a perception that most patients, if everything were perfectly equal, would rather take a pill than have to be poked and get an infusion and sit in an infusion room. Although, as I discussed at the beginning, there are positives and negatives of both forms of administration.
And you mentioned patients need to make sure there's a clinical trial data to support treatment decisions. How do you recommend a layperson search for and interpret the complicated data in order to have a meaningful discussion?
Well, that's an important question, and I think that you really have to hope that, and not, it shouldn't just be hope. You have to feel confident that you've enabled a relationship with your provider, that you trust the provider to be able to help give you the information, and that the provider's knowledgeable of the information that's out there. I think it's like any physician interaction. It's at some level you have to develop a trust. The best way, I think, to develop the trust is to have a good understanding. So, if a treatment regimen is being proposed, I think it's very reasonable to say, were there studies that were done, and what were the studies show about that? It can be very overwhelming to try to go through the literature without a lot of medical training. There are certainly some resources, including those by the LRF, that have tried to distill some of these into something that's easier to read for the layperson. Challenge with that is sometimes those are out of date because the science changes so quickly. So you really, I think, just need to have a very good relationship, and always the possibility of a second opinion if you think that would be helpful.
Great. Thanks so much for clarifying that for everyone. Our next question is, what are the best oral therapies that you see now or in the future that are promising to treat relapsed refractory mantle cell lymphoma?
So mantle cell lymphoma is one of the diseases that is a great example of how oral therapies have really changed the approach to treating that disease. Certainly for the first decade and a half that I took care of patients, we always used intravenous therapy for mantle cell lymphoma. And we have two drugs, lenalidomide and Ibrutinib, and then Acalabrutinib as well as Xanabrutinib, the cousins, that have shown really great activity and have FDA approval for the treatment of mantle cell lymphoma. And a third drug, venetoclax, which is also quite active, although has not yet been approved for mantle cell lymphoma. How best to use these, what order to use them in. At this point, we don't have great data that guide us, although I think there's an evolving consensus that if you look across all of those, that the BTK inhibitor class of drugs is probably more active and better tolerated than the other two agents. So for that reason, it's often the first choice. But many patients with mantle cell lymphoma will end up at one time or another on any of those drugs because none of those interventions appears to be definitive treatment for mantle cell lymphoma. I've had patients who have been on those treatments for years, so it's a very positive thing, but the expectation is at some point patients need to be prepared to switch to something else.
Can oral chemotherapy for relapsed follicular non-Hodgkin lymphoma lead to a cure?
Well, that's a very challenging question. I'm not trying to dodge the question, but I think there's a lot of debate in the field about how you define cure in a disease like indolent lymphoma. Historically, we've said that many indolent lymphomas are not curable diseases with standard treatment. However, when we give upfront chemotherapy with antibody treatment, we know that 10 years later, about 40% of patients remain free of lymphoma. The question is, how long do you have to wait before you call something cured? And with indolent lymphoma, I think the feeling is you have to wait a very long time because we've all in our clinics seen recurrences that can occur between year 10 and year 20. At some level, how important is it if you're going to go 10 or 20 years before the disease comes back? And if it's readily treated again, it may be that cure is not so critical. And the other reason to dodge the question is we just don't have the follow-up yet with a drug like lenalidomide in indolent lymphoma to know whether a subset of those patients are definitively treated. What we know is that a subset of patients seem to have very long remissions, but the drug hasn't been around long enough, I think, for us to definitively feel comfortable using the word cure.
Great, thanks for tackling that one on for us. I know it's always a tough question. Our next one is, many oral therapies are listed as under investigation. Which BTK inhibitors look most promising?
Well, BTK inhibitors, we have 3 that are approved in various settings that I put on the slide, the Acalabrutinib, the Xanabrutinib, and the Ibrutinib. So there are other ones that are being developed. What I would say as a clinical investigator is that when we already have 3, the added benefit of a 4th or a 5th one is probably less than new classes of drugs. And I think that in cancer, particularly these forms of lymphoma, I'm more excited in many situations about new classes of drugs than trying to figure out marginal differences between drugs that sit within a given class.
Great, thank you. I'm just waiting for some more questions to come in. So let's wait a second here and give people a chance to write into the Q&A chat. Our next one that just came in is, when deciding between oral agents, how much do you weigh the decision between twice daily and once daily dosing?
That's an interesting question. For me personally, for most patients, it's not a major deciding factor. I'm pointing it out that when you have to take a drug twice a day, that's twice the possibility of forgetting or missing a dose or something like that. That said, most of my patients seem to be very willing to take what they need to. And if for some reason we think a twice-a-day drug is the most appropriate drug for them, it's not something that in my practice is a major deciding factor on how to give the treatment. I will say there are studies in other diseases, and we should pay attention to them, that suggest that as soon as you take a drug more than once a day, the adherence goes way down. So, and I think we all have the experience, if we're put on antibiotics and we're supposed to take them 3 or 4 times a day and it's a new drug, it can be very hard to remember. So we should pay attention to that.
Thank you. This is a question that probably affects many people around the country right now, but person says COVID has restricted travel to cancer treatment centers. Will local cancer specialist care be as effective?
So, I think that we have a very large rural area, catchment area. So even before COVID, we had to figure out ways to work with local oncology centers in our region because it's just not practical for patients to be driving hours to get to see us. And I think that in many scenarios, there are very productive partnerships between larger centers and community-based centers that enable shared expertise and convenience for the patients. The other point I would make is that one of the things that COVID has really done on a positive note is transform telemedicine and video visits in a way that none of us ever would have done, I think, without being forced or pushed in the setting of COVID. Back in April and May, when it was a big surge here, we switched most of our outpatient visits to telemedicine and video medicine. Things have come back to a balance now where probably about 20% of our visits are conducted that way. But the point is we have the capability to do that, as do most centers, so that it could be that at some level there's another entry point to these larger centers that didn't used to exist before. If it's intimidating or limiting to go to the center physically, you may be able to communicate with them through those other mechanisms.
Great, thank you. Our next question is, I think we have time for a few more questions. Can you speak to the new combination therapy of venetoclax and obinutuzumab?
Yeah, so venetoclax and obinutuzumab combination is a very active regimen for CLL. It probably has some activity in some of the other lymphomas as well, like mantle cell lymphoma. Venetoclax itself in CLL is a very active therapy. And how important the obinutuzumab addition is can be a little bit hard to tease out. For example, with Ibrutinib, we know in older patients, in fact, that graph that I showed you, bring it up one more time, find it here. So in this particular trial, there were 3 arms, Ibrutinib alone, Ibrutinib plus rituximab, and bendamustine plus rituximab. And I really focused on how Ibrutinib compared to bendamustine. But another aim of this study was to look at the arms that had Ibrutinib and Ibrutinib with rituximab. And you can see that in this particular study, there was no benefit of adding the rituximab. The Ibrutinib alone seemed to be quite active. So, in other situations, there haven't always been these types of randomized studies to determine how important each component of the treatment is. I think that venetoclax is likely doing the heavy lifting in the venetoclax obinutuzumab regimen, but adding obinutuzumab may help to get to that minimal residual disease undetectable state, that very deep remission, again, that may be a new goal for treatment in the future.
Great. Our next question is, can you talk more about what the newer classes of drugs that you mentioned, EZH2 and nuclear export, how they are different from other classes?
Yeah, so first, they're very different from other classes. All of these classes of drugs are really quite different from each other. Just because you don't respond to Ibrutinib doesn't mean that you won't respond to, say, lenalidomide or venetoclax. And they're as different from each other as chemotherapy may be different. And in some cases, there may be more differences between oral classes of drugs as between a given oral drug and a given intravenous drug. The EZH2 inhibitor is a targeted agent, we would call it. It, again, is focused on this gene called EZH2. And in the subset of patients that have mutations in EZH2, it seems to have particular activity. Interestingly, there's some activity in patients who don't have mutations in EZH2 as well, but it's a little bit less active in that group. One of the things I'm excited about with that drug is it really is the beginning of targeted therapy in lymphoma. This is what's been used a lot in many of the solid tumors. So like lung cancer, if you have an ALK mutation, you get an ALK inhibitor. In melanoma, if you have a BRAF mutation, you get a BRAF inhibitor. So this is one of the first examples in a lymphoma where if you have a mutation, in this case EZH2, we have an inhibitor that you can get. And I think we're excited because it's the beginning of what we hope will be more of these agents out there to allow a more precision approach to treatment. The nuclear export inhibitor selinexor in the laboratory really looked great. There have been some side effects associated with selinexor that have made it a little more complicated to give in clinic, although with new dosing regimens, the selinexor seems to be better tolerated. It's not nearly as targeted as, say, a BCL2 inhibitor or an EZH2 inhibitor. And again, I want to say that being targeted doesn't always mean it's better. So, our chemotherapy is very untargeted treatment. That's why there's so many side effects. Yet in some situations, in diffuse large B-cell lymphoma, for example, it's curative. So we have to be careful that just because something isn't targeted doesn't mean it's worse. It's just a different mechanism of action.
Great. And we have time for one more question. There are two questions here. They're a little different, so you might want to take on one at a time. The first is about deep remission and if it is attainable in mutated or unmutated IGHV. And the second part of that is when measuring deep remission, is MRD the only way to do that? Okay,
so the first question I'll answer just very briefly. So mutated and unmutated is probably a patient with CLL. There are really two main flavors of CLL. It has to do with the cell of origin, meaning what was the cell that developed mistakes in it that eventually led to the cancer. And unmutated CLL seems to have a slightly inferior prognosis with chemotherapy than mutated CLL. And for a long time that was a very important prognostic factor. Less so with the oral agents. And it's still something that we routinely measure, but how important it is as far as treatment decisions when we're giving most patients oral agents anyway is not so clear. I'm going to broaden out the answer to the other question and say that this concept of MRD and deep remission is really still in its infancy or toddler stage. There are some commercially available tests available. There are also some tests that have been designed in academic centers or laboratories that are available both on a research basis or on a clinical basis. Each one of these tests has a slightly different methodology. Again, you can look at both blood and bone marrow. You can do these tests in various ways, and how sensitive they are at detecting and what the threshold is remains relatively unstandardized. And I think, therefore, it can be challenging to make a lot of clinical decisions based on these tests because the data sets are really all over the place on what tests were used. Obviously, the deeper remission you get, probably the better. And however, if you take a test that is too sensitive, you may end up picking up small amounts of cells that have no meaning. So this is a component of the field that I think we have to pay particular attention to research. And what I say today will probably be out of date in 6 months. It's changing that quickly.
Great. Well, thank you so much, Dr. Friedl, for taking the time today. Obviously, everyone on this call really appreciated it. We had a bunch of questions that came in. Some of them we didn't have time to get to, but you spent a good chunk of this call talking about them, and obviously everyone is really engaged and interested in this important topic. So we really thank you for taking the time to talk to us today.
My pleasure. I thank everybody for your attention, and hopefully this was informative.
Of course. And thank you again to everyone who joined us on today's call. We hope you found this information both informative and also hopeful. We'd also like to thank our sponsor again for making this program possible, Pharmacyclics and AbbVie Company, and Janssen Biotech, and Karyopharm Therapeutics. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this evaluation, as these are important for helping LRF to ensure they deliver the most useful and meaningful programming to you. And with that, I'd like to thank everyone for joining us again, and have a wonderful day.